everyone. I'm Andrea Valdez, Senior Vice President of Audience Strategy at The Atlantic. Welcome to the Atlantic Festival. Over the course of the next week, we'll talk about many of the issues that are top of mind for Americans this fall: the global pandemic, climate change, the state of our politics, and much more. For the next hour, we will talk about an equally important topic: health equity. We know that the global pandemic has only exacerbated the inequities in health. Communities of color, low-income and rural communities continue to suffer from bias and a lack of access to quality care. So what can we do about it? Hopefully, we can come up with some answers to that question. But before we dive in, I want to thank our underwriter, Genentech, for supporting the Atlantic Festival. I also want to remind all of you watching that you can join the conversation in the Q&A tab on the side of your screen. Now, let's get started with our first interview.
For our first conversation on ensuring health equity, please welcome Marcella Nunez-Smith, Senior Advisor to the White House COVID-19 Response Team, and Katherine Wu, Staff Writer at The Atlantic. For our first conversation on ensuring health equity, please welcome Marcella Nunez-Smith, Senior Advisor to the White House COVID-19 Response Team, and Katherine Wu, Staff Writer at The Atlantic.
Dr. Marcella Nunez-Smith, thank you so much for joining us.
Thank you.
So many health inequities existed long before the COVID-19 pandemic began, but recent events have absolutely exacerbated them and brought national attention to them. What do you think is the current state of affairs? Is there more awareness of these issues now? And how has the conversation around health inequities changed since the start of the pandemic?
Yeah, thank you so much for that question, because I think it's the absolute right framing for our conversation and time today. I mean, COVID-19 did not create these inequities that we see in health, but it certainly did take advantage of them, right? And I think this reality was known to some of us and to many communities, but not to everyone. And I think this collective witnessing we've had as a nation, we cannot unsee that. So we now, I think, have, in perhaps a way we haven't before, some shared baseline of understanding for exactly how all of these different systems, I mean, we talk of social and structural drivers of health. What we're talking about there is people's access to housing, right? Access to food, access to steady employment, right? I mean, access to consistent, high quality, trustworthy healthcare, all of these things, right? And so the reality is that the inequities that existed before have been laid bare by COVID-19. And I think, the call to action is there for all of us to be responsive in a way that maybe as a collective we haven't before. For the administration from the beginning, this was very clear from the president and the vice president. It was going to take a whole of government response to this pandemic, and we had to center it in equity. I mean, without intentionality, you will never achieve equity. And so in the short term, that's about COVID-19 resources, PPE, testing, therapies, of course, vaccination, making sure everybody has equitable access, but also having a future look and a future watch too, to say if we're really going to recover from this pandemic and build resilience so that it doesn't happen in the same predictable way next time, we have to be very, very, very focused and committed to change and transformation.
Absolutely. So I'm so glad that you brought up social determinants of health. And I know that has been a big focus of your research to date. Can you expand a little bit on how these factors have shaped the experience of the pandemic for marginalized populations? I think it becomes so easy to talk about, health equity in a vacuum, but that just makes the problem so much more complicated. How do we start to appreciate that?
Yes, and that's right. And the statistics are staggering and numbing when we talk about, this phrase of disproportionate burden or disproportionate impact. But it can really, I think, easy to forget that we're talking about individuals, right? Families. Mm-hmm. When we talk about grief and what is an unequal burden of grief, right? Loss in terms of actual loved ones and members of our families and our communities, but loss of a lot else too. I mean, we have the economic impacts in the very same communities that have been the hardest hit by COVID-19. So I think it is important, right, when we talk about health equity, that we know the conversation isn't one that's limited to healthcare. In fact, when we think about what causes or contributes to variations in health outcomes, actual healthcare, clinical care services, maybe 10 to 20% of that difference explained by healthcare. Now, let me stop there and say, I don't think we should accept that. That's 20% of variance that shouldn't be there. We should be able to guarantee everybody high quality healthcare in our country. But really the bulk of the pie, the bulk of what drives health outcomes are these other drivers, right? And we have to make sure that people have access to good nutrition, not just calories, not just food, but nutrition, that people have access to housing that is stable and also of high quality, right? That people have opportunities for advancing education, economic prosperity, and wellness. And all of that is part of a conversation about getting to health and wellness. We see in COVID-19, it is a microcosm of so much else. And so that's why we've had to be so deliberate. And this is in concert with great partners, and partnership is always at the core of advancing equity, because communities absolutely know what's needed to thrive and be successful. But, we, I think, have made notable progress as an administration focusing on equity, but of course, there's so much more work to do.
Absolutely. And yeah, I guess thinking about the work that needs to be done, you are the head of the COVID-19 Health Equity Task Force, and you clearly have a monumental task ahead of you that sort of transcends the boundaries of this pandemic. Where do you start? Can you tell me about some of the early concrete steps that the task force has taken to start to, address these inequities and make sure they carry forward beyond the pandemic?
Yes, it is a deep honor to serve as chair of the Presidential COVID-19 Health Equity Task Force. On the president's first full day in office, he signed an executive order that brought the task force into being. And I do often pause and think about, just in that very act, how historic and monumental it is to have our president stand up and say, health equity is at the center, at the core of the work that I want done in this administration. Mm-hmm. And so the task force has brought together just an extraordinary group of people, including many people who are representing agencies within the US government, but also bringing people who have the lived experience, the situational expertise from the very communities that have been hardest hit, the ones we know are minoritized, marginalized, medically underserved, all coming together in an advisory capacity to say, how can we think about response and recovery in a way that centers equity? How can we lift up and make visible what has been invisible for so many and for so long? And so the group, we've been meeting every month. I don't even want to talk about the hours. The commitment of the task force members is so incredible. We're supported by just a phenomenal federal staff team as well, and coming together and has been sharing in public meetings every month interim recommendations, really focusing on some of what we think are core issues related to equity, whether it's equitable access to resources like vaccines, like testing and therapies and PPE, whether it's long COVID, just thinking about some of these issues we know will be with us, that we have to be building into our recovery plan. And so given the urgency of the work, the group is looking to be able to submit final recommendations this fall to the president.
Great. So, I mean, while all of this work is going on, there are still millions of people in this country who are living through these inequities in real time. And, some of your research at the Yale Equity and Research Innovation Center has centered around, findings of distrust among Black Americans toward the healthcare system, how that's affected their experience of COVID-19. The fact that these inequities still exist right now, how has that played out, especially through the vaccine rollout? And, while these inequities still exist, how can we sort of meet people where they are right now?
That's right. That's right. And that's our work, right? We have to meet people where they are. And I think, we have to continue to have grace and compassion for understanding that for,
Here,
people who haven't gotten vaccinated yet, there are myriad reasons. And it's not for us to jump to those conclusions, but to be respectful, right? To ask to make sure that particularly in their instances when, what I say is this is rational pause and rational deliberation, particularly in communities that have quite frankly known primarily even only harm from these establishments that now come forward and say, we're here to help, be that healthcare systems, be that the government. Very early on, the president came out and said, we have to acknowledge that people of color in this country have just not gotten the respect and the dignity. We know, all of us can name all of the various experimentation. I mean, the U.S. Public Health Service study of untreated syphilis in the Negro male at Tuskegee, right, comes to mind, of course. Henrietta Lack, so many, but not only historical, right, but contemporary. People can look to last week, to last month, when their family member tried to get care and they felt treated differently, treated poorly, based on race or based on income or based on insurance status. And so, acknowledging this truth and this reality is the first thing, and then owning it on our side to say, we shouldn't expect trustworthiness, we have to earn that, right? And you earn it in time and showing up and being responsive. And so, that's why we are grateful to be in conversation with people who say, where have you all been? Everybody's here now to talk about a COVID-19 vaccine, but I want to talk about community violence, right? I need to talk about job opportunities and the lack thereof. I want to talk about my child's school. And we're here to do all of that because that's the work. It's a syndemic for these communities, not a pandemic. And that's the frame that we need to have moving forward. We need to find solutions in partnership. The work is not going to be work that's done overnight, right? That is long committed work. But in the interim, we're going to make sure that there is equitable access to all of the life-saving, life-preserving COVID-19 resources. And we're going to make sure that there are trusted messengers who are well-informed that can connect with these very communities that have been the hardest hit.
Absolutely. So sticking with this line of thinking on trust and vaccines, especially, we're kind of in new territory now that vaccine mandates are starting to roll out. How have you approached that particular communication problem? And do you think we're at a particular juncture in ensuring that it's not just about, access, but also acceptance and making sure that people don't feel blindsided at this point in time?
Yeah, the president came out with a set of policies to really move our country to where we need to be. We have all the tools in the toolkit. We are so fortunate as a nation to have the supply here to vaccinate everybody in the country that's eligible. We know that the vaccinations, work. The vaccines are safe, they're effective. Of course, they've been free, and the commitment has been there to continue to make sure it's easy, it's convenient to access. People need to access the vaccines, and to your point, the information that they need, and from the people that they want to hear it from to understand all that goes into their own personal decision making. But we have to get people vaccinated. Many people were waiting for full FDA approval. We now have that in Pfizer. We've certainly been, and again, much credit goes to state, local leaders around, making sure that we address structural barriers, that people have transportation support, childcare support. The president has continued from the beginning and advanced even recently unpaid time off for people to get vaccinated and their family members to get vaccinated. But look, we know that vaccine requirements work. We've seen them work. And the reality is 75% of eligible adults have already at least initiated their own vaccination series. So I think that's notable. Many people have stepped up already and done their part to keep themselves safe and their community safe. And so we just have to, of course, we're working to get to 100%. And it's important for everybody to have a safe workplace. It's important for our children, I'm a parent, to go to school safely. And I think it's key for all of us who are showing up to get healthcare, for us to feel confident and secure that the people providing us healthcare are vaccinated. And so equity is us making sure that everybody in this country has that opportunity to connect with vaccination.
I really like that way of framing it. So as one final question to close out our conversation, it sounds like there is actually quite a bit to be optimistic about. What are you most excited to see play out in the coming months? And how do we keep this momentum going as we hopefully start to bring the pandemic to a close?
Yes. Well, let me tell you, I continue to hold just a great degree of optimism. This is a historic moment. And, as I say, I do think we can meet it. And I'm very excited about that. I think that there are conversations we're having now that are just long overdue, quite frankly. But, I have an opportunity. It's a gift to be in many spaces and many conversations. And, I feel even across these various virtual platforms, the sincere commitment across really diverse groups and coalitions forming that say, we're going to make sure this isn't a 15-minute conversation about health equity in our country, but that this is sustained, ongoing work, that we're going to pull all the levers, right? Policy levers, but also hearts and minds levers. I mean, that is so key. And it is in those individual conversations and connections where I find and derive the most hope. Because, in a way, I feel like we're seeing one another anew. And I think that is so critical and important. And look, we have another generation. We need to give them something better than we've had to date. And I think that's highly motivating for all of us. What are we going to pass on to that next generation, to our children, our legacy of an equal society? Let's make that a reality.
Wonderful. Dr. Nunez-Smith, thank you so much for joining us today.
My pleasure. Everybody, please be well.
Our next conversation is produced by our underwriter, Genentech. Ending the systemic root causes of health inequity, engaging and empowering medically disenfranchised communities. Please welcome Quita Beeler Highsmith, Vice President and Chief Diversity Officer at Genentech, and Ruben Mesa, Director of UT Health San Antonio's MD Anderson Cancer Center, and Stephanie Monroe, Executive Director of African Americans Against Alzheimer's.
Hi, I'm Quita Highsmith, Vice President and Chief Diversity Officer at Genentech, and I'm here today to have some real talk about the urgent need to address healthcare inequities. We have fielded our second health equity study. We have found that both patients and healthcare providers agree that the healthcare system needs urgent reform. And today I'll discuss those findings and explore how we can partner across the industry to address the needs of underrepresented patients. Joining me in this important conversation is two change makers who I have known for several years. Dr. Ruben Mesa and Stephanie Monroe. And I'll ask Dr. Mesa to go first to introduce himself and then followed by Stephanie.
Wonderful. Well, thank you so much, Quita, and honored to be here. I'm Ruben Mesa. I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio MD Anderson.
And I'm Stephanie Monroe, Executive Director of African Americans Against Alzheimer's, which is a national network of Us Against Alzheimer's.
Thanks, Stephanie and Dr. Mesa. So let's get right into it. Last year, Genentech fielded our very first health equity study, looking at 2,200 patients, 300 each from LGBTQ, Black, Hispanic, low socioeconomic status, meaning they made less than $35,000 a year. And what they told us was there's a crisis of trust in the healthcare system, and they feel that the system is actually rigged against them. This year, we decided to field that same study again, but adding a new component, adding healthcare professionals. And so this year, when we broadened that study to include the healthcare professionals, what we found is that both the patients and the healthcare providers believe that there still is a crisis of trust in the healthcare system. And it's actually deepened over the course of the last year during COVID-19 pandemic. The data also shows us that only half of the healthcare professionals and less than half of the patients believe that the healthcare system acts in the best interest of society. And while 3 out of 4 patients, 76% of the general population report access to reliable healthcare, the medically disenfranchised, Black, Hispanic, Latinx, LGBTQ low socioeconomic status, they live in a different reality. And they report that only 56% of them report that they have access to reliable healthcare. We also found that more than half of the medically disenfranchised patients continue to feel the system is rigged against them. So Dr. Mesa, after hearing these findings in year 2, what are your reactions to this? And as a professional doctor in Texas, have your patients expressed similar concerns?
Well, it's an important study that you guys have done, and the data are very sobering. I'd say there was a baseline levels of issues, and our center is in a Hispanic majority community, with 69% of individuals being Hispanic from San Antonio all the way down to the Rio Grande Valley. I think it's multifactorial. I think there has been some history of abuses in the past with the healthcare system, clinical trials, and other things with people of color that have led to some levels of trust. I think there can be communication issues, language issues. There can be issues of a fear that the healthcare system can be a direct conduit to everything from the immigration system, from a punitive standpoint, to their employers or insurers that can be negative. I think many things have been helpful in terms of trying to advance communication, and also for patients to be able to see individuals that look like them in terms of both healthcare providers, both physicians, nurses, and others. I do fear that this last year there has been so much public kind of intentional generation of mistrust of the healthcare system for secondary political gains that unfortunately has made this worse. People's distrust of the vaccine, has only been heightened for all sorts of reasons of secondary gain. So it's an unfortunate, and it's made our hole, I think, deeper to dig out of.
Absolutely. Stephanie, so what do you think about this info and how it impacts patients of color?
Well, I think you guys have done a remarkable job in being able to generate data that I think helps us understand what really is happening. I often say, perception is reality. And if the perception of communities is that they can't trust the healthcare system, or that the healthcare system has unique motives that aren't necessarily to benefit them or extend their health because maybe they're not as valued as the majority population, those perceptions are reality for those individuals. And so we see people not only not going to the doctor regularly, even if they have comorbidities that need to be addressed. We see people refusing to engage with the health system entirely. Affordable Care Act was wonderful, but it's not wonderful if people don't use the benefit of the resources that they have. And so I also think that, your data was wonderful in terms of showing disenfranchised individuals, but it actually goes much broader than that. My parents, for example, 88 and 82 years of age, not meeting the criteria that you had in terms of social economic status, but they're experiencing the same thing. They have difficulty understanding a lot of times what the doctor is saying. It's not just misinformation sometimes that you read about publicly, but it's too much information being given and not given in a way that people can really understand it. And so as sometimes as healthcare professionals try to impress their patients, that can cause more mistrust, because part of communicating is communicating in a way that people can understand. Break it down so that I can take something from it, and don't make me feel somehow that you are spending a different amount of time treating other people, maybe from the majority population is different. And for me, you're just going to get me in, get me out, not really worry about whether I connect or not. So I think this is a huge ongoing issue.
And let me ask you, Dr. Mesa, one of the things that's in the study that we heard is that the vast majority of healthcare professionals say they genuinely care about patients' well-being and seek the best treatment options for them. Yet the patients in the study actually said they stopped seeking care because they didn't think the healthcare practitioner understood them. What are your thoughts around this?
Well, I think there's a lot of important communication issues which arise, and the prior point regarding communication, I think, is key. One lesson we've learned in South Texas is that many of our Latino patients, it's a very family-oriented culture, and there's typically a family health expert. And that might be, a pharmacist, that might be a respiratory tech at the hospital. But that it is critical for key discussions to have that family healthcare expert present, and that the level of the conversation really be geared to the patient, in a language they understand, but very important that that family healthcare expert really understand exactly the options being presented. So I do think, most healthcare workers clearly do care about their patients and want the best for them. I think it's really a communication issue that has, many layers to it. And I think frequently the pressures of time in clinic office visits and such really exacerbate this. Also, our system can make patients feel very much disenfranchised. Their first interaction is typically one with billing and copays and being harassed about insurance before they've really ever seen anyone. So our systems somewhat tell patients what matters. What matters first is that we're going to get paid for your care. And only then do we get around to the care. I think that's a message that people receive.
You know what, in the last minute or so, what can we do to make a difference to empower patients to rebuild trust? I'll start with you, Stephanie.
Well, I think Genentech in particular has done an excellent job. I really appreciate the plans that you guys have to create a site alliance where you're really taking responsibility and not just identifying the problem, putting a face on the problem, which is critically important, but being part of the solution. Going into communities, being part of the community, partnering with people who are already trusted and who are known to community members is brilliant. And I think it's going to lead to a lot of great success. Helping providers and sites understand how to communicate with patients, how to give to patients and give back to the community, building and training, making sure that people enter sites that have individuals who look like them, and then demanding accountability is really going to be critically important. So often, disenfranchised communities don't have access to the high qualities of care of other sites, and Genentech's involvement in this, I think, will really be a game changer.
Dr. Mesa.
I would add to that, the Mesa Cancer Center, we're proud to be one of the 4 initial sites in an alliance with Genentech, really trying to advance this, particularly as it relates to clinical trials and cancer clinical trials. And you're right, taking a look at the problem from a 360 perspective. There's many aspects, the design of studies, eligibility, communication, navigation, and recognizing some of the challenges that can be overrepresented from, individuals that have hourly paying jobs that, leaving work to receive healthcare is a huge burden. So there's many layers to this, but we're excited to be partnering with yourselves. I think you guys are clearly working to be part of the solution. It's a difficult challenge, but I'm confident with, all of the efforts being placed from many key stakeholders around the country. I know we're going to make a difference.
Thank you so much, both of you, for sharing your knowledge and your insights with us. And certainly for me personally, I believe we have to be bold. We have to speak up to ensure that communities of color are participating. And I'm hopeful that by sharing this data around listening to marginalized voices and patients and asking providers to take that one extra step to hear them out, that we can identify opportunities for intervention and we can disrupt the status quo. Thank you, everyone.
For a session on addressing root causes, please welcome Benjamin Perkins, CEO of Wholesome Wave, and Stacey D. Stewart, President and CEO of March of Dimes. Vann Newkirk, a senior editor at The Atlantic, is here to lead the discussion.
I am happy you all were able to join us today. Thank you for being on. Today we're going to spend a little time talking about root causes and solutions of 2 issues that are near and dear to my reporting and obviously near and dear to your work. We're talking about nutrition security and also talking about the crisis of Black maternal and infant mortality. Ben, I'll start with you. We're using the term here today, nutrition security, and it's one that I think a lot of people here may not know. I think a lot of people have heard about food security, but not necessarily nutrition security. Can you tell us the difference?
Yeah, that's first of all, thank you for having me here. It's great to be here. And we have been quite intentional at Wholesome Wave in talking about nutrition security almost from the very beginning of the organization, so 15 years ago. And the idea was it just wasn't about getting people food. It was about ensuring that folks got the right food. And in our case, healthy fruits and vegetables. As a wise person once observed when I was having a discussion with this person, they reflected back what I was saying and they said, so what you're saying is somebody could be fed and yet starving. And that's exactly the point. The idea is that in a lot of communities, we talk about food deserts, but a more accurate term is really food swamps. That there's lots of energy dense food in the community, but there's not necessarily nutrient dense food. And so we are very intentional in making that distinction.
And what would you identify as some of the key root causes for nutrition insecurity?
So I've been in public health for 20 years. I started first in HIV/AIDS. Then about 6 years ago, I went to heart disease, to the American Heart Association, and now I'm in the world of food and nutrition insecurity. And one of the things I observed in my 20 years is that in looking at the populations that are most impacted in HIV/AIDS, in heart disease and stroke, and now nutrition security, surprise, it's the same communities. So I like to say that you have to identify that common ancestor. And I would say that the common ancestor, the root of all of this is structural racism. And racism defined by the Racial Equity Institute, they talk about a system of advantage that privileges white folks and disadvantages anyone who is not white. And what happens from there is that it cascades out into all aspects of civil society. So in education, in housing, in employment, and all of those things. So at the root of it is structural racism, and we begin to see how it plays out. There's also an issue, obviously, of income inequality, and that affects not just Black and brown folks, but white folks. We talk about Appalachian, those kinds of places. But certainly if we look at the root and we look at the populations that are most disproportionately impacted historically, it's racialized.
Now, Stacey, I imagine that some of what Ben just said is extremely applicable to your work as well. And again, we're focusing on Black maternal and infant mortality. We know that Black women are 3 or 4 times more likely to die in childbirth than white women, sometimes more in some areas. And we know that Black infants are much more likely to die in infancy than white infants. Can you tell us a little bit more about the root causes there and what's going on in this health crisis?
Yeah, no, it's great. And certainly a lot of what was just said is definitely applicable to the work we do at March of Dimes around maternal and infant health. A lot of our work does focus on how do we make sure that women are healthy before pregnancy, during pregnancy, and after pregnancy. And unfortunately, as you mentioned, right now, even before this COVID pandemic, we were already facing a pretty significant maternal and infant health crisis in the U.S., where, as you mentioned, Black women are 3 to 4 times more likely to die as a result of pregnancy and childbirth. We have Black babies twice as likely to die as compared to white babies before their first birthday. We are considered in the U.S. to be the most dangerous developed nation in the world in which to give birth. And one of the things that we know is that the CDC has even said that about 60% of all of the maternal deaths that happen could actually be avoided. Could be avoided with the proper diagnosis and the proper care being delivered at the right time, with really listening and responding to symptoms that women express that they're having when they're having it. But all of that doesn't explain exactly what is going on with Black women and why so many Black and brown women, I would say, and Indigenous women are facing such significant and bearing such a significant brunt of this of the disparities that exist. What I would say is that a lot of the care, and one of the things we know about health in general, is that most of it is determined by how we live. About 80% of our health isn't determined by what happens in the doctor's office or in the clinic. It's really determined by how we live. And so if we're living in communities where we are facing discrimination every day, the stress and anxiety that goes along with that, if we're living in substandard housing, if we don't have access to nutrient dense foods close to where we live, if we don't have access to all the things we need to live a healthy lifestyle, that is going to end up affecting our lives. And unfortunately, too many Black and brown women are living in these communities. And we're the ones who are facing the most impact with respect to racism that is embedded in our society today. And that plays out both in communities in which we live and in the healthcare system as well. So that is obviously contributing a lot to the disparities we see and the poor outcomes that we're experiencing.
Now I'm going to turn to ask both of you about solutions and the work that your organizations are doing in just a moment. But I do want to make sure that the audience is in the Q&A asking any questions they have. I'll make sure that we get to a couple of them before we get out of here. But turning towards those solutions, turning towards facing the problem, both of you have identified a broadly similar, probably the same set of factors underlying everything about where you live, about how you live, about your place in America, in the country. And I wanted to ask you both how your organizations are orienting themselves, are gearing up for this kind of fight that involves really going up against some of the most enduring inequalities and hardships in America. And I'll Stacey first.
Sure. Well, at the March of Dimes, we're sort of attacking on multiple fronts. The first is we're talking about systemic failures, and the only way to really reverse systemic failures in the healthcare system, systemic racism and institutionalized racism that exists in society, is really primarily through policy change. We have to make sure that we're enacting policies and that we're funding the solutions that can actually address some of these issues. It starts with a very basic of just healthcare coverage. Are we actually giving people the healthcare coverage that they need when they have problems, when they're having challenges, when women are pregnant and when they need care and when they're ready to deliver their baby? Can they do that affordably? The other thing that we're seeing is that we have so many what we call maternity care deserts, to play off the food desert idea a little bit. We have over 50% of all the counties in this country that have no access to OBGYNs or hospitals that offer obstetric services. So we have big gaps in care. Even if you have healthcare coverage, you may not have healthcare access. And then we have to make sure that we level the playing field for women of color. We have to make sure that we're doing more to invest in their health by making sure that they're living in communities that are healthy, but that also we address whether they're at home or in the healthcare system and being served by the healthcare system, especially when they show up at the doctor's office, that they don't have interactions with their healthcare providers that make them feel as if there's some sort of racist interaction going on. That if implicit bias exists, and we know based on research that there is implicit bias in society, there's implicit bias in the healthcare system, we at the March of Dimes are funding implicit bias training and helping healthcare providers, and even now moving to students, helping students understand that when they become healthcare providers, whether you're a nurse or a doctor, that you have to recognize, do you have implicit bias against a woman of color? And if so, how do you address it so that the highest quality healthcare can be provided to women of color? Those are just some of the things we're doing. But on the policy front, we're trying to lead the charge to make sure, working with others, and the Black Maternal Health Caucus and so many others, that Medicaid expansion, Medicaid extension, postpartum, 12 months, the healthcare coverage, that implicit bias, and all these things can be addressed. It's really on multiple fronts. The Momnibus Act is something that is really important in this, and we're glad that Congress is moving on a dozen different bills that are designed to really address some of these basic underlying issues.
Now, Ben, I want to pose the same question to you, but I also want to make sure that we have some time to talk about that you talk a little bit about the produce prescription program, which I think is really neat, and I'd love to hear more about.
Yeah. So the one thing I'll start off by saying is one of the ways I like to think of nutrition security or insecurity is the fruit and not the root, no pun intended. So the fact that we're talking about nutrition security at all means that it is the result of certain things. To echo what has been said, I think also about what Dr. Nunez-Smith also talked about, the idea of policy. It really, if we're going to get population level health and health improvement, policy is a key lever. So for us, we have a National Produce Prescription Collaborative, which is thought leaders, academic research institutions, folks who are doing produce prescription programs out in the field, working together to influence policy. And by policy, certainly I think the holy grail of this is Medicare and Medicaid, because they are the largest insurers, getting them on board with the idea of funding produce prescription programs. Right now, Medicaid has something called an 1115 waiver, which several states have adopted, which allows them to allocate funds for what are considered social needs. And so two big ones are housing and food. And so the idea is that some of those funds can actually be directed to health systems who a provider identifies that someone is housing insecure or food insecure. They can actually then write a prescription that allows that person to get access to healthy fruits and vegetables for housing. So, but that's a demonstration project. And we know that ultimately, of course, what we want to do is look at the data from that to make the case as to why produce prescriptions are an important element in improving the health. But we also, again, in the long term, realize that we want that as a permanent feature in Medicare and Medicaid, because we know for the long haul, that's how you get the kind of population level health impact that we seek to have.
Right. One question we have coming in, I think for both of you, is with all of these really far-reaching and really ambitious both policy at the national level and local initiatives, how do we measure success? How do we think about how to assess how these programs are doing and what are our goals? I'll give it to Ben first.
Yeah. So for us, there are what I like to call transactional metrics and transformational metrics, and both of those are important. All too often, too much airtime has been given to the transactional metrics, but I'll give you some examples of the kind of metrics that we're looking at if we're trying to prove that produce prescription nutrition incentive programs actually work. We want to be paying attention to things like body mass index, but more importantly, things like A1C, systolic blood pressure, those sorts of things, because what those suggest is if someone is in a produce prescription program and they lose weight, their blood pressure is improved, their A1C is improved, then we're headed in the right direction. And there's a lot of compelling evidence of what happens when you can lower A1C, you can lower blood pressure in terms of the long-term health consequences on an individual and a population, obviously. So those are the kinds of things we look for. But we're also looking on a transformational level at the impact in the community. Does it increase social cohesion? And so we have something called our FED principle. And the idea for us is FED is really around looking at fidelity to communities, driving with equity, and honoring the dignity of those we serve, because we believe that that's a critical component, especially when talking about historically marginalized communities and some of the misconduct, as others have pointed out, in those communities.
Now I want to give it to Stacey very briefly as we close out. Just a word about success and how we measure it.
Yeah, well, I think a couple things. At the March Dimes and with many other partners, we are looking at the metrics around maternal mortality and also maternal morbidity, because there are 700 to 900 women that die every single year as a result of pregnancy and childbirth, but there are another 50,000 women who come close to death. And one of the things that I was really pleased, I had an opportunity to testify back in 2018 in support of the Preventing Maternal Deaths Act, which actually gave funding to ensure that every state would have a maternal mortality review committee, because one of the things that we had not been doing very well was collecting really good data. I mean, it's really hard to measure success if you're not even collecting good data on where you are and don't have good baselines. The data that has started to be collected because of these maternal mortality review committees that are now in just about every single state in the country is allowing us to collect better data on what deaths exist and what are the different interventions that can be put in place in order to make sure that we can prevent them. So one of the things that we're able to do now is to create a system across the states to see where we are with maternal deaths and morbidity and try to measure our progress, and also look at the strategies that can make a difference. One of the big contributors to maternal mortality and morbidity are health-related cardiovascular challenges. So frankly, if we're doing the right thing with food and measuring A1C and all those things, maybe we'll be able to also see whether or not we're making progress with respect to women being healthy, especially before pregnancy and during pregnancy. But I think the last thing I just want to say about this, we're in partnership with the Department of Health and Human Services to look at a 5-year program to actually reduce maternal mortality, working in hospitals around the country. We're looking at the rates of maternal mortality in those states. We're looking at the rates of how we can reduce elective or low-risk C-section rates, which can also be a big contributor to maternal mortality and morbidity. We want to make sure that women are healthy before, during, and after pregnancy. So there are different metrics that we can measure and use at the state level to see if we're making progress. And with the maternal mortality review committees, really re-examine what strategies we're putting in place to see if they're effective or not, and actually hopefully scale that in other states when we see what's working. Just like what's being done recently with over $300 million being allocated from the federal government to support things like home visiting programs. We'll be able to put those programs in place at scale and then do evaluation to see if they're effective as well. But so far, those kinds of programs are also being shown to be effective. So I think there are a lot of things we can put in place. We're glad that the government is really stepping forward to help us not only track and measure and collect good data, but then measure the success of our initiatives over time. And that's certainly, I think, going to help lead us to success, staying focused on data and outcomes, and iterating our work over time.
Well, thank you both for sharing so much about your work and for taking the time to be with us today.
Thank you so much.
Thank you. My pleasure.
For our final conversation on community-based solutions, please welcome Allison Arwady, Commissioner of the Chicago Department of Public Health, Francis Crevier, CEO of the National Council of Urban Indian Health, and Hector Vargas, Executive Director of GLMA. Catherine Wu is back to moderate the discussion.
All right. Thank you all for joining us today. Unfortunately, Francis could not join us at the last minute, but Hector and Allison, we are so glad to have you here. Let's jump right in. And Allison, I will start with a question for you first. So your department recently released Healthy Chicago 2025, which is a 5-year roadmap for how to address gaps in health equity. And one of the goals is to close the city's racial life expectancy gap. Can you tell me about 2 or 3 action steps that are needed to make that happen and how that's going to inform the city's strategies beyond 2025?
Yeah, absolutely. Thanks so much for having me. So at the Chicago Department of Public Health, we had done the work for our 5-year plan, Healthy Chicago 2025, mostly before COVID. We didn't have to change a word of it when COVID started because this focus on the racial life expectancy gap in Chicago is deep and unfortunately it's long lasting. Black Chicagoans live on average 9 years approximately less long than other Chicagoans. And we talk about the 5 drivers of that fact and the things that we're going to do to address it. The biggest cause of that gap is actually in the chronic disease space, but then we also look at differences in gun-related homicide, differences in infant mortality, infectious diseases, HIV, COVID, and then finally opioid overdose. And so in all of these areas, we're working on the policies, the systems, the environments that can actually enable progress. We've got specific programs, things like home visiting for new mothers, like we were just hearing about, or really making sure we're working on building systems that allow people to access care regardless of their insurance status, their immigration status, or their inability to pay. So we've really been trying at the health department to think about how to help people access care, but more important than health care from public health are the environment that we live in and what do we do to actually make sure if we want to think about diabetes, yes, it's important that people are able to access the care for that, but more, what are the spaces where they're able to access healthy food, healthy exercise, even have safe neighborhoods to be able to be outside in. And I think COVID has really opened everybody's eyes about the need to think about the history of systemic racism, the ongoing daily inequities that are in our life and in our healthcare and public health systems, and then invest in ways that let communities make decisions about where and how to use resources to improve health in those systems.
Absolutely. Great. And Hector, now a question for you. So we know that LGBTQ individuals are an essential part of any discussion on health equity. What are some examples of how the mental and physical health of LGBTQ community members have been impacted by discrimination, and how visible is this discrimination?
Hi, everybody. Thanks for allowing me to be part of this conversation. It's great to be here. It's a great question to start with. And I want to point to some research that was done by our friends and colleagues recently by the What We Know project at Cornell University, which shows the extensive body of research that anti-LGBT discrimination increases the physical and mental health, poor outcomes for mental and physical health for LGBTQ people. These include things like depression, increased levels of depression, anxiety, suicidality, substance use, including tobacco use and psychological distress. And when you look at the physical physical health aspects, these include elevated stress hormone levels, increased levels of cardiovascular disease, poor self-reported health, and certainly some of the physical health factors include increased risk for certain forms of cancer. So the discrimination is a huge priority, or ensuring that there is non-discrimination and non-discrimination policies and laws in place for organizations like GLMA. We are an organization of LGBTQ health professionals, but ensuring that there is non-discrimination is one of the first priorities, and we've seen some advancements in that, especially with this new administration at the federal level, restoring some of the protections under the Affordable Care Act that prohibit discrimination based on sexual orientation and gender identity. in healthcare settings. But there's so much more that needs to be done in terms of preventing and prohibiting discrimination.
Absolutely. So for the next couple questions, I'll focus a little bit more closely on the pandemic. So Allison, a question for you. You've talked about how equity is really at the center of your city's COVID-19 response, and the Chicago COVID Corps is a really great example of how outreach efforts can sort of meet community members where they are. Can you tell us a little bit about how this program works and how it's already starting to benefit vulnerable communities?
Yeah, absolutely. And I do think that any success we have had here in Chicago has been because this has been an all hands on deck approach across government, across philanthropic partners, medical system, community-based organizations. So from very early on, like really the first just few weeks of the pandemic, we decided here in Chicago under Mayor Lightfoot that it wasn't just enough to talk about the long-standing racial life expectancy gaps, which we were already framed around, actually formed what we called the Racial Equity Rapid Response Team. We don't usually think about addressing race equity with a rapid lens, but COVID, right from the beginning, 70% of our deaths right at the beginning there were in Black Chicagoans. We knew rates of chronic disease already were driving that gap, and there was a lot of need to think about who are the messengers, where are we putting resources, what kind of data do we need, and how do we make sure that we are doing the listening and not the talking in terms of how to move the needle rapidly in these communities. And that's where we started. And then from that, we've used every opportunity that we've had. Honestly, we don't always get it right, but we've said every time it's not enough to be efficient, it's not enough to be first, it's not enough to get it to everybody. It's about making sure we're putting more resources where they're most needed. So for example, when it came time to hire contact tracers all over the country, people were hiring contact tracers. We said, we're not going to hire a call center. We're not going to work with an academic center. Here's a job opportunity on the south and west sides of Chicago, which are heavily Black and Latinx areas. We knew a lot of people needed work during the pandemic, and we said, here's an opportunity to hire people with no education requirement. Worked with the Chicago Cook Workforce Partnership with the biggest grant we've ever given, and hired people who had never done this kind of work before, but had interest in it, partnered with city colleges to do an earn as you learn component, paid well above minimum wage, and hired about 600 people through community-based organizations in our most impacted parts of the city. Those folks became contact tracers, then they turned into vaccine ambassadors. They were part of the work going door to door within communities. Right now, they've been important voices. It's been a really good example of hiring, but not just hiring, building that expertise in partnership with community-based organizations, people who look like communities and can build that trust. And I think that's the sort of work that if you don't, in our experience, if you don't start from the beginning saying, what are we going to do with a racial and ethnic equity focus, you're not going to get there. And I could go on, but throughout all of the pandemic, where we've had opportunities, we've said, let's create an equity index and let's prioritize vaccine, resources, money, funding in the spaces where it's most needed. And I think it's part of why Chicago has done as well as we have.
Great. And so, Hector, I think another thing that the pandemic has made very apparent is the importance of data, public awareness of data, and having inclusiveness in data. So, I think one thing that you and your organization have brought up is key to ensuring health equity for the LGBTQ population is the inclusion of data related to sexual orientation, gender identity, and really making that an important part of health statistics. What is lost when those data are excluded, and how can we sort of fit them back in a way that will be sustainable going forward?
Thank you. That's a great question. So, in the context of COVID, even though LGBTQ people have certain risk factors that may make them more vulnerable to COVID, like tobacco use, like other comorbidities, the fact is that very few states collect any data on LGBTQ or sexual orientation and gender identity in terms of COVID testing. So we don't really know the extent of the impact of COVID on the LGBTQ community because we don't have that data and statistics. Now, this lack of data has existed well before COVID and the pandemic hit us. And this has been a priority for the LGBTQ health advocacy community for many years. why in June, as part of Pride Month, 180 organizations joined a letter calling for increased data collection at all levels in the healthcare systems, everything from electronic health records to inclusion in clinical trials to all of the public surveillance and mechanisms and surveys that the governmental agencies institute, including at the federal, state, and local levels. These are things that we really need to be able to understand the extent of health disparities that impact the LGBTQ community, and also to direct resources and programs to address those health disparities.
Great. And I'll close with a question that I think I would love to hear an answer from both of you for. So I think one really important way to ensure more equitable healthcare really begins with training healthcare providers to be knowledgeable and inclusive when they're seeing patients from all backgrounds and who hold many different identities. What are some of the barriers to building this trust? Why is it important? And what are some of the moves we can make next, certainly within the context of the pandemic, but also beyond that? Allison, I'll start with you, and then we'll go to Hector.
Sure. So, it's such a big, important question. And I think, I like this point around the data. It certainly is a place that I think we have a lot of work to do in general, not just in terms of collecting it, but even not making assumptions, asking, learning how to sort of build in questions about identity as part of an interview, right from the very beginning. We see assumptions made certainly about sexual orientation, but we see assumptions made about race and ethnicity and language and all sorts of things that can be major barriers and can really turn people off from wanting to really engage or have any kind of trusting relationship from the beginning. So I think even thinking about, we've tried to work on some of the language that we use when we're calling and interviewing people and asking people, setting up that, in all of these spaces, there is space for you. And so there's basic things you can do in your systems. I also think, just to choose, one more quickly, but it's a big one, is thinking about how we fund healthcare, and that the fact is people who may have certain, public insurance or people who are uninsured see the health care system often as against them from the beginning, where they know that the provider may be receiving less money to see them, or where they simply don't trust, because it is often true that you can get these very, very large bills here in the US. And one of the things that's been so interesting about the COVID vaccine is how much education we've had to do to say, truly, this is free. Truly, you cannot get a bill. And when I think about barriers, I think that cost and sort of the socioeconomic status that overlays often in longstanding ways, other ways in which communities can be marginalized based on identity, is something that we should be working on, thinking about how we reimburse. How can we work on making sure that no matter what your insurance or lack of insurance is, you are able to access appropriate health care. So those are just two right off the top, but there's all kinds of low-hanging fruit in this area.
Great. Hector?
So Allison really hit on some great points there. I think that when you look at from the LGBTQ perspective, what we talk about a lot is ensuring that providers of all disciplines at all levels of their training are provided training in both the cultural and the clinical competency needed to treat and care for LGBTQ people. So the creating the welcoming environment for LGBTQ patients is key, and can go a long way toward eliminating some of that distress that has developed over the years with healthcare communities. But when you get beyond that, when you get past that, you also need to be clinically competent in the healthcare issues that impact LGBTQ people. And there are things or trainings like the GLMA Annual Conference on LGBTQ Health, which is actually happening as we speak. And I invite you to find out more about that. But there are lots of training programs out there that are devoted to making sure that providers of all disciplines have the tools and the skills necessary to care for the LGBTQ community.
Great. Thank you both so much for those incredible answers. That is all we have time for today. And thank you to both of you and to everyone for tuning in. That actually concludes this hour of Atlantic Festival programming. But this is only day one of the festival. There's a lot more ahead, so please check your schedule for more details. And we will see you all again soon. Thank you so much.
Thank you.
Thank you.
While we're on a break, we encourage you to network with other attendees and visit our expo booths. To participate, select the networking icon located on the left-hand side of the screen.